Hey guys, it's Nurse Gwenny. Let's talk about an extraventricular drain. We just call it an EVD for short. First of all, what is it? Extra, meaning outside of. Ventricular, we're talking about the ventricles of the brain, and that is the reservoir for CSF, or cerebrospinal fluid. It's the slippery juice that kind of cushions our brain inside our noggin, and it's a drain. So why would we ever want to drain any of that CSF? We need that fluid. Well, first of all, we have to understand the Monroe-Kelly doctrine. The Monroe-Kelly doctrine states that our head is a fixed volume. There's nothing we can do to make that bigger on our own. A brain surgeon can come in and help us, but that's a whole separate video. And 80% of what's inside the noggin is brain matter. 10% is blood and 10% is CSF. If any one of those increases, something else has to decrease to accommodate the displacement that's happening with the increase of one of those elements. And so why would we ever put an EVD in a patient? Good question. It's for anybody who has an increasing intracranial pressure. So something inside of here is increasing. It can be an intracranial hemorrhage, and so that means that 10% blood is now becoming 15 or 20, and something has to displace. And usually what displaces is the brain matter. The brain will start to swell and herniate. This can happen if we have an injury to the brain and the brain's swelling, and so it starts displacing blood. Well, we certainly don't want that to happen, because the brain is a hungry, hungry hippo, and it's constantly gobbling up oxygen, and there's no reservoir. Like, I could put a tourniquet on my leg and it would be okay for a few hours until you got me to definitive care, surgery, or whatever I needed. With my brain, we cannot impede that cerebral perfusion, because the brain, 3 minutes and it's a goner, right? And so here we have the EVD. So we place this so we can drain off that CSF. If the brain is swelling or if the brain is bleeding and it's displacing one of the other contents, we want to try to drain off some of that CSF as a temporizing measure until we can fix what's going on in the actual brain. We can take care of the brain swelling. We can evacuate the hemorrhage, or whatever the primary pathology is happening inside the brain. And so why am I standing in front of my pool filter? Well, I want to show you a few things about the EVD that are important for us to remember in transport medicine. You have the catheter. Look at this picture that I borrowed from the internet. We have the catheter goes directly into the ventricles. The brain surgeon will drill a hole into the nogger and stick the end of that catheter into the ventricles. Then it has tubing coming out of it, and it goes to a transducer. That transducer has to be at the level of the tragus, this ding-a-ling-a-ling thing here on our ear, because it is a gravity-fed system. It functions off of hydrostatic pressure controlled by gravity. And so if I had this hose, let's say that this is my EVD, and it's going into the hole that we drilled into the patient's head. If I raise this, let's say this is the transducer, if I raise it above the level of the pool, well, everything that's in here is going to drain back into the pool. That's defeating the purpose of having the EVD. Whereas if I drop it really low, below the level of the pool, it's going to drain all of my water out of the pool. And so that's why it's super important that you're always making sure you've got the transducer at the level of the tragus, because that's in line with where the ventricles, that's kind of status zero of where we're trying to measure. But in transport medicine, we move a lot. We're constantly up on the cot, load them into the helicopter, bring them out, coming down. We're constantly moving. And so it's imperative that during movement of the patient, you clamp that, which is essentially going to go clamp it right here to make sure that we're not accidentally dumping a whole bunch of CSF out of the patient or bringing it up too high and draining a whole bunch back in, therefore increasing that intracranial pressure. So make sure you've got that transducer at the level of the ventricles, which we can't see them from the outside. From the outside, it's just your tragus. Some other things that we've got to make sure that we're doing when we're managing the patient with an EVD. Watch that intracranial pressure. We can either drain or monitor the EVD pressure. We can't do both at the same time. So ask your sending ICU nurse or the physician at the bedside, hey, are we draining? How much are we draining? How often are we draining? Because usually we like to monitor these patients all the time and then drain every 30 or 60 minutes, depending on what the orders are. So make sure you're communicating with the team to know what to expect during transport. Additionally, we're going to do constant neuro checks. And what's the best way to check a neuro status on a patient? Their pupils. Your pupils are a window into the soul. And so we're going to check, are they at the same diameter that they were, or are they now blown, or is one bigger and one's not? So checking the frequent neurostatus of our patients. As well, if we're trying to control the intracranial pressure, let's make sure we're not doing things to increase or worsen the intracranial pressure. So something like agitation or pain is going to cause the patient to increase their intracranial pressure. If they're not intubated and that patient starts to vomit, or if they are coughing, if they are on the vent, they're bucking the vent, that's going to increase their intracranial pressure. If they have a C collar on, that's going to impede the venous outflow from the brain, which that can increase the intracranial pressure. So blood pressure management is also super important on these patients. We know that cerebral perfusion pressure is simply the MAP, our mean arterial pressure, right, controlled by our heart pushing blood out into the circulatory system, minus our ICP, minus the pressure in the brain. So this is pushing up, this pressure is pushing down. The cerebral perfusion pressure is the difference between the two. So we want to have a normal cerebral perfusion pressure, which is about 60 to 80, because we want to feed that hungry hippo of the brain plenty of oxygen. So we have to send it blood, right? So we're overcoming that ICP. Additionally, we don't want to drop their blood pressure, right, too low, because then we're not sending blood up there. And if we are sending too much blood up there, that's going to increase that bleeding that we've got in the brain. So there you have it. That was a really wildly disorganized, hopefully helpful video on extraventricular drains, or an EVD. My neuro nurses, jump in the comments. What else do you want us transport people to know? Because we're just jack of all trades, master of none. If you're a master of this, jump in the comments and teach us a thing or two.